I am Dr. Carin, a pediatrician. So I will be discussing to you the endocrine diseases in children. So let's start first with disorders of the hypothalamus and pituitary gland. When you say pituitary gland, if you look at the anatomy of the pituitary gland, it is located at the base of the skull in a saddle-shaped cavity of the sphenoid bone. And that's what you call sella turcica. It is considered as the master gland because it has a central role in the hormonal system. So the anterior constitutes, the anterior lobe constitutes approximately 80% of the gland, while the remaining 20% is occupied by the posterior lobe. So as you can see here, pituitary gland is the major regulator. So it receives signals from the hypothalamus and responds by sending pituitary hormones that provide negative feedback at the level of the hypothalamus and the pituitary. So this slide would show the different hormones secreted in the posterior lobe. So we have the oxytocin, which is the love drug, wherein it secretes in response, or it's being secreted in response to uterine distension and stimulation of the nipples. It stimulates smooth muscle contractions of the uterus during childbirth, as well as milk ejection in the mammary glands. And we have the ADH, or the vasopressin, which is secreted in response to dehydration, blood loss during pain, and when the patient has certain stress or any person with stress. And it decreases urine volume to conserve water. It decreases water loss through sweating, and it raises blood pressure by constricting arterioles. So we have also hormones secreted in the anterior lobe. So we have the luteinizing hormone, which stimulates the secretion of estrogen and progesterone in females, and also testosterone in males. Whereas prolactin stimulates milk production, and the ACTH, or your adrenocorticotropic hormone, stimulates secretion of your glucocorticoids, or your cortisol, by the adrenal cortex during the body's response to stress. And then we have the melanocyte stimulating hormone. When in excess, it can cause darkening of skin. So let's start with the hypopituitarism. So when you say hypopituitarism, this is a clinical syndrome of deficiency in pituitary hormone, pituitary hormone production. And this may result from disorders involving the pituitary gland, the hypothalamus, or even its surrounding structures. So when you say panhypopituitarism, this refers to the involvement of all the pituitary hormones. So this denotes underproduction of the growth hormone alone, or it can be in combination with deficiencies of other pituitary hormones. And the incidence is 1 in 4,000 to 10,000 live births. And that is based on Nelson's. Okay, so I've mentioned this, that it occurs when the anterior and posterior lobes of the pituitary gland loses its ability to make the hormones, resulting in multiple pituitary hormone deficiencies. And the physical symptoms of this hypopituitarism would depend on which hormones are no longer being produced by the gland. So these are the different clinical features of problems with the pituitary gland. No? So when there is a problem with the growth hormone, so this could be the manifestations. No? You have dwarfism, lethargy, premature aging. In ACTH deficiency, you have problems, so we call that Addison's disease. And TSH, so you have these problems, no? And then prolactin, you have too little milk. FSH, so it can explain the infertility or late puberty of certain individuals. And the luteinizing hormone manifested by amenorrhea and impotence. Whereas in the posterior pituitary, the oxytocin, so it can manifest as prolonged labor or diminished milk production. And when there's problem with vasopressin, so there might be manifestations of diabetes insipidus. The urine might be very diluted, okay, and then coupled with polyuria. So what are the etiologies of your hypopituitarism? So it could be congenital or acquired. Okay? And in adults, the most common cause of hypopituitarism is still the adenomas or the pituitary pituitary tumors. Although traumatic brain injury as a cause is being more frequently recognized, no, for this. So hypopituitarism resulting from pituitary adenomas is due to the impaired blood flow, no, to the normal tissue. So causing compression of that normal tissue or even interference with the delivery of the hypothalamic hormones via the hypothalamus hypophyseal portal system. Okay, so this is for your congenital hypopituitarism. So it could be a perinatal insult. Okay, it could be traumatic during delivery or during birth asphyxia. It could be interrupted pituitary stalk or absence, no, or an absent or ectopic neurohypophysis. Another causes of congenital hypothyroid, or hypopituitarism, are genetic disorders such as growth hormone deficiencies and gonadotropin deficiencies, or even defects in the development of the central nervous system. Okay, and then some causes could be idiopathic. So for acquired hypopituitarism, the main cause is a lesion that damages hypothalamus, the pituitary stalk, or anterior pituitary hormone deficiency. And the most common lesion here is a craniopharyngioma. And the most frequently seen manifestation is diabetes insipidus. Okay, so these are the manifestations, no? These are the causes, sorry, for the acquired, no? So it could be brain damage, presence of pituitary hormones or non-pituitary, pituitary hormones. Infections could be one, infarction, autoimmune disorder, and other causes, okay? So what would be the clinical manifestations of this hypopituitarism? For congenital hypopituitarism, the birth weight of the infants is almost always normal. Okay, the birth length may be slightly decreased, but it's not that obvious during birth. And postnatally, the growth is severe. The growth failure is severe. And with regards to bone age, it is usually delayed. And with the genitalia, during childhood, there is micropenis, but it can be normal for body size in adults. And then puberty is most often delayed. And the good thing here is sexual function and fertility is still normal. So with regards to hair, it's sparse before the age of 7 years old. And there is frontal bossing. The forehead may be prominent. The skull at birth may have a normal head circumference. But later, there can be craniofacial disproportion. That's because of the small fascias of that particular individual. So it's small, the fascias would be small, and there would be hypoplastic nasal bridge. The orbits may be shallow, and there is delayed eruption of the teeth. And patients may manifest with blue sclerae, high-pitched voice, and infants during in the nursery, this could be one of the considerations that you have to think of, no? When there is hypoglycemia in an infant, or even in children. So this can be a manifestation. Some of the milestones, motor milestones, may be delayed, and there might be hip dysplasia and limited extensibility of the elbows. And the skin could be thin and prematurely aged. So there can be presence of osteopenia, jaundice, hypoglycemia, and some electrolyte disturbances. Okay, so this is a picture of a patient with hypopituitarism. So this one is a patient with growth hormone deficiency. Okay, this one is a normal child. So this one is one with growth hormone deficiency. Okay, so how about patients with acquired hypopituitarism? So the manifestations, especially if the cause is a tumor, so usually the patient would complain of headache, would manifest vomiting, some visual disturbances because the optic nerve might be involved. There might be pathologic sleep patterns, decreased school performance, okay, because of that lesion there. Presence of seizures, no, because of the compression of the inside, no, in the brain, or even presence of polyuria and growth failure. If patients' cause is a craniopharyngioma, so most often the problem is a visual field defect. Okay, there might be optic atrophy, presence of papilledema, or even cranial nerve palsy. So some patients with other causes may have loss of weight, asthenia, sensitivity to cold, okay? Failure for sex maturation, or there might be regression of the sexual development, atrophy of gonads with amenorrhea, and even loss of pubic hair. And there is dramatic slowing of the growth of these patients. Okay. So how do we evaluate? Okay, how do we evaluate patients with hypopituitarism? So the diagnosis of hypopituitarism is made by measuring the basal hormone levels in the morning, no? Usually a fasting status, or you can perform stimulation tests if necessary. So the 6 anterior pituitary hormones, your growth hormones, prolactin, LH, FSH, TSH, and ACTH, as well as the target hormones, can be measured via sensitive and reliable immunoassay techniques. No? So we have the following. We have the following tools in the evaluation for this particular patient. Okay, so you can have imaging also, no? You can do your CT and MRI to confirm for the presence of a mass. Okay, I've mentioned already this blood test in the laboratory. It's also important to do genetic analysis or looking at the family tree of these patients. Okay, so I've mentioned also the levels of these particular hormones. Okay, so with regards to treatment of patients with hypopituitarism, medical care consists of hormone replacement, okay, and also the treatment of the underlying cause. So glucocorticoids are required if the ACTH adrenal axis is being impaired. So the treatment should be started as soon as possible to narrow the gap in height, no, between patients and their classmates during childhood to have the greatest effect on mature height. Okay, so they should have that effect, no, in their height. So the recommended dose of the human growth hormone is 0.18 to 0.3 milligrams per kilo per week, and this is during childhood, and higher doses can be used during puberty. So the recombinant growth hormone will be given through subcutaneous, and it is given in 6 or 8 divided doses. So the maximal response of this may occur in the first year of treatment. Okay. So let's go now to hyperpituitarism. So this is the reverse of your hypopituitarism. At this point, there would be excessive production of the growth hormone. So this is a chronic, progressive disease marked by hormonal dysfunction and startling skeletal overgrowth. So it can appear in 2 forms. So in children and in those affected infants, it's in the form of gigantism, whereas affected adults may appear in the form of acromegaly because this happens after the epiphyseal closure. So when you say gigantism, this is actually rare, it's sporadic, no? This is where the pituitary gland secretes the growth hormone, no, and then excessive secretion of the growth hormone. So the growth hormone that's being secreted is in excess, therefore it augments the growth not only with the bones but also with the connective tissues, with the muscles, not during childhood or during adolescence before the end of puberty, meaning to say the epiphysis is still open. Okay, so what would be the effect? No, there would be increase in the height and formation of additional soft tissues. And some individuals may achieve a height in excess of 8 feet. So what could be the etiology of this gigantism? So in most of the cases, it's a non-cancerous pituitary gland tumor. Okay? It could be genetic. It could be due to a syndrome that causes unusual growth of the bone tissues, and you call that McCune-Albright syndrome. We have also this hereditary condition, the Carin complex. So patients may have spots, the non-cancerous endocrine tumors and spots of patients with darker skin. Men type 1 could also be one of the causes, and also patients with neurofibromatosis. Okay, so this neurofibromatosis, it causes tumors in the nervous tissues. So what could be the manifestations or the clinical features of patients with gigantism? The cardinal feature, of course, is the longitudinal growth acceleration secondary to growth hormone excess. And this is very evident during puberty. And the common signs would also include large hands and feet, very thick toes and fingers. Okay, there is bulging of the jaw and forehead. Okay, the facial features could be very coarse. And then these are some of the manifestations or features: large head, the lips, tongue, no, and because no of some problems no of in the development no, there's enlargement of the skull no, some patients may manifest some behavioral and vision problems, headaches, or even nausea because of the tumor. So this is a picture of one of the tallest actually the patient with gigantism. So the girls there are having normal height. Okay, so it's almost double. And this one is yeah, so this is Sultan Hossein. So they were featured in the Guinness Book of Records. So this is the tallest with a height of 8 feet and 1 inch. And then this is Ping Ping manifesting dwarfism. Okay, so with a length of 2 feet and 5 inches. So how do we diagnose patients with hyperpituitarism? Okay, definitely you can ask for a history, no? And then the development of those clinical features as time goes by. No? And then if you want to rule out presence of pituitary tumor, then you can do either a CT scan or an MRI. You can also do your OGTT and of course doing blood tests to rule out the growth hormone, to determine the levels of your growth hormone, even the high prolactin level, increased insulin level, or the growth factor 1 levels. And to manage, since the main etiology is the presence of a tumor or a presence of a mass, so it is surgery is the first line of treatment. Okay, so you can have this transsphenoidal adenectomy or hypophysectomy. Okay, so it requires early detection and strong treatment to prevent excess production of growth hormone, and therefore it improves life expectancy. And radiation therapy here is another option if the surgery will not provide a complete cure. Okay, so that is for gigantism. How about in adults? So this is what you call acromegaly. So you can see here the series of pictures of this patient affected by acromegaly. So comparing the facial features here from this year and then the latest, which is 1988. And then this one also, this is a normal, okay? And this is a patient having the acromegaly. So patients may have enlargement of the distal parts of the body, increase in the size of the skull, very broad nose, okay? The tongue is enlarged. So look at this also, the hands of the patient with this acromegaly. And because of the expansion here in the face, so the teeth may become separated. And as I've mentioned, there can be visual field defects. And the earliest symptom of acromegaly is presence of fatigue. Okay, so let's now go to diabetes insipidus. Okay, so when we talk about diabetes insipidus, we are talking about disorders on the pituitary lobe of the pituitary. The disorders of the ADH or your vasopressin. So patients usually would manifest polydipsia and large volumes of dilute urine. Okay. So this is the normal, no? So the pituitary gland here, as we all know, will send your ADH to the kidneys, okay, in order to control how much urine is made. Whereas in patients with diabetes insipidus, particularly the one having the central diabetes insipidus, because the pituitary gland does not make enough ADH, the kidneys would make a lot of urine. So that's what you call polyuria. Okay. So there are certain types of diabetes insipidus. So we have central diabetes insipidus and a nephrogenic diabetes insipidus. When you say central diabetes insipidus, this results from genetic mutations in the vasopressin gene. Okay, and it could be trauma in that area, or presence of congenital malformations in this hypothalamus and pituitary, presence of neoplasms, increased metabolism. So it is related to the vasopressin, due to lack, no, of the hormone vasopressin, or your antidiuretic hormone. So this can be due to the injury, no, to the hypothalamus, or even the pituitary gland. And when we talk about nephrogenic diabetes insipidus, this can occur when the kidneys do not respond properly to vasopressin. Okay, so this nephrogenic diabetes insipidus would result from the failure of the kidneys to concentrate the urine. And patients with this disease would typically produce around 12 liters of urine per day, assuming that a bladder volume is just 500 ml. No? So this volume of urine will, of course, necessitate voiding approximately once per hour throughout the day and night. Okay. So this can result from, it could be genetic or acquired, no? So these are the causes of your central diabetes insipidus and nephrogenic diabetes insipidus. So with central, it could be affecting the head, no? Secondary to trauma or surgery maybe, or presence of tumor, presence of occlusion, or secondary to an infection. Whereas nephrogenic diabetes insipidus could be due to systemic diseases involving the kidneys, patients with multiple myeloma, sickle cell anemia, those having polycystic kidney disease or pyelonephritis or infection, no, of the urinary tract, and then certain medications may cause also a nephrogenic type of diabetes insipidus. So what could be the reason, no? What could be the reason for this or the mechanism, no, for your central diabetes insipidus? So with central, we have this loss of your vasopressin producing cells, okay? And this causes deficiency in your ADH synthesis or even the release. So because of that, there would be inability to conserve water. Therefore, there would be extreme polyuria and polydipsia. And how about nephrogenic diabetes insipidus? So here on the kidney part, there is depression of your aldosterone release, or the inability of the nephrons to respond to antidiuretic hormone. So still the manifestation could be extreme polyuria and polydipsia. So what could be the signs and symptoms of your diabetes insipidus? polyuria with urine output of 5 to 15 liters. Imagine that, 5 to 15 liters per day. And because of that, no, patients, of course, would desire, okay, more fluids, no? Some patients or most patients would desire for cold fluids. And as a result of this polyuria, there might be marked dehydration, okay? And this can be evidenced by dry mucous membranes, presence of dry skin, or even presence of weight loss. And because patients having polydipsia, there would be, because of the water intake, there might be fullness, always the gastric area or epigastric fullness can be felt by patients, and even result to anorexia. And it can interrupt the sleep, of course, because it's almost every hour that the patient will wake up to urinate. So what would be the diagnostic test results in patients with diabetes insipidus? So they might be having high serum osmolality, and that osmolality is usually above 300 milliosmoles per kilogram of water. Whereas if you check the urine osmolarity, it's very low. It's about 50 to 200 milliosmoles per kilogram of water. And the urine specific gravity is less than 1.005. Because of the dehydration, it can cause increase in creatinine, serum creatinine, and the blood urea nitrogen. And when you do your water deprivation test, there would be a positive test for that, okay? So how do we manage diabetes insipidus? So the main objectives of the therapy is to replace the antidiuretic hormone. This is a long-term program. And another objective is you have to ensure an adequate fluid replacement. And therefore, for us to deal with this, we have to identify and correct the underlying cause. So treatments, so you can replace by giving vasopressin with intranasal or IV DDAP or your desmopressin acetate. You need to correct dehydration and electrolyte imbalances. You can give your thiazide diuretics, okay, in order for you to deplete sodium and increase renal water reabsorption. And you have to restrict the intake of both salt and protein. Okay, so let's now proceed to disorders of the thyroid gland. Okay. Okay, so this is your thyroid gland. We all know that it is located here, okay, the root of the neck, and it has two lobes connected in the middle by isthmus. So it secretes three hormones, the tetraiodothyronine, or the T4 or your thyroxine, the T3 or your triiodothyronine, and your calcitonin. And these are the important functions of your thyroid gland. It increases the BMR, it stimulates growth in children, it increases oxygen consumption, stimulates protein synthesis, and also it has an effect with regards carbohydrate, all foodstuffs, metabolism of these foodstuffs, particularly carbohydrate, lipid, and vitamin metabolism. Okay, so let's just review the development and physiology of your thyroid. So during the 7 weeks gestation, you can recognize the thyroid to be bilobed in shape. And by 10 weeks of life, So there would be thyroid follicle cells and colloid formation. And by 4 weeks, there would be thyroglobulin synthesis already. And iodine trapping may occur by 8 to 10 weeks. At 12 weeks of gestation, the T4 and T3 synthesis will occur. And by 6 to 8 weeks, so the hypothalamic neurons would synthesize your TRH, and the pituitary portal vessel system begins its development by 8 to 10 weeks. And the TSH secretion is become evident by 3 months of life. Okay, so the main function of our thyroid gland, of course, is to synthesize these two hormones. And the only known physiologic role of your iodine is in the synthesis of these two hormones. So the recommended dietary allowance of iodine is 30 micrograms per kilogram in 24 hours for infants, 90 to 120 micrograms per 24 hours for children, and 150 per 24 hours for adolescents and adults. So, so this is the hypothalamic pituitary thyroid axis. So we have your thyrotropin releasing hormone. So what's the role of your TRH? So it stimulates this pituitary to release the TSH. And the TSH will stimulate this thyroid gland to release both the thyroid hormones T4 and T3. Okay, and here in an average size person, the thyroid gland will produce 6 milligrams per day of your T3 and 100 micrograms per day of your T4. And in the peripheral tissues, like in the liver, in the kidney, brain, and skeletal muscle, this T4 will be converted to T3, okay, by the iodothyronine deiodinase, okay? And this RT3 is an inactive byproduct after deiodination. So what happens if there is deficiency in the production of thyroid hormone? So it could be a primary or a central hypopituitary hypothyroidism. So when you say primary hypothyroidism, there is a defect, no? The decrease or the deficiency in the production of the thyroid hormone is due to a defect in the gland itself. Whereas the central one, the central hypothyroidism, is a result of reduced TSH stimulation. So it could be congenital or acquired. So for your congenital hypothyroidism, usually the deficiency is detected at birth. So the most cases of congenital hypothyroidism are not hereditary, okay? And most often it can be due to thyroid dysgenesis. Okay, some could be familial. It could be one of the being caused by inborn errors of thyroid hormone synthesis. Or sometimes it could be associated with goiter. So congenital hypothyroidism is one of the conditions that can be seen or that can be screened during newborn period. That's part of the newborn screening program. So with regards its incidence, it's 1 in 4,000 newborns worldwide. Okay. With regards to etiologic classification, so as I've said earlier, we have both the central and the primary. So with central, so these are the causes, no, of your central hypothyroidism. So it could be mutations in this area in the pituitary affecting the TSH, no, and so on, no. And then with primary hypothyroidism, usually it's a plastic, no, or a defect in the development of the thyroid hormone, the thyroid gland itself. Okay, so these are the causes, no, of your primary hypothyroidism. Okay, as I said, the most common cause of congenital hypothyroidism is thyroid dysgenesis. So patients may have ectopic gland, and also some patients may have these causes, so some mutations in the TSH receptors, inborn errors of the synthesis of your T4, its secretion, or even its utilization. This can be one of the causes. Maternal autoimmune thyroiditis could be one also. Mothers who are having Graves' disease, who are on medication, could be another reason for congenital hypothyroidism. And even iodine deficiency, no? There are areas wherein there is what you call endemic cretinism. So what could be the manifestations of congenital hypothyroidism? Actually, infants may be protected for the first few weeks of life. Some infants may have normal development, no symptoms during the first few weeks of life. But later on, some patients may already have manifestations like increase in the head size. Okay, patients, if you try to examine their fontanelles, particularly the anterior fontanelles, it's very large, and the sutures are wide. And then the tongue is usually out. No, there's presence of macroglossia, presence of distended abdomen with umbilical hernia, very rough and dry skin. Sometimes patients may have a mottling of the skin. Some may have deafness and other congenital anomalies. And then with regards some observation, patients may have poor feeding. Okay, so poor or even fair feeding. Constipation could be one of the manifestations. Patient could be lethargic. Sometimes they would say, my child or the infant or my baby is very quiet. My infant is very good, no? Because the patient does not cry. Okay, so but you have to be sometimes you will get worried about that, no? Patients may sleep more. They need to be awakened to feed. Hoarse crying, presence of hypothermia, and then some patients may have cardiomegaly or presence of murmur, and then macrocytic anemia and so on. Okay, another manifestation is a presence of prolonged physiological jaundice. When you say physiologic jaundice, it's normal up to 2 weeks of life. Okay, but there are some infants who are exclusively breastfed. This physiologic jaundice may be extended up to 3 weeks of life. Okay, but patients with congenital hypothyroidism may even have prolonged jaundice beyond 1 month old. Okay, so you have to consider. No, that's one of your differential diagnoses. So what will happen if a child or if an infant is not diagnosed at a later age? So this could be the sequelae. So they may have slow linear growth, poor IQ, ataxia, fine motor, or even gross motor incoordination, presence of hypotonia, spasticity, speech disorders, attention deficit, okay, strabismus. So usually there is brain delay. The brain development delay in patients who are undiagnosed. So That's why it's really part of the newborn screening program it's very important now to have your children, to have your babies be screened during newborn period. So the diagnosis with primary hypothyroidism, this is very characteristic, no? With very low serum T3 and T4, and of course, you have an elevation of your TSH. So the TSH here is extremely sensitive index of primary hypothyroidism. So this very high levels of your TSH. And then when you do your x-rays, there is a significant delay in the skeletal maturation, or also delay in, there is a dysgenesis of the epiphyseal area. You can also do some imaging studies, also thyroid antibody study, no, if you are entertaining autoimmune thyroiditis. Okay, so this could be some of the radiologic findings in patients with congenital hypothyroidism. So there might be retardation, no, of osseous development. So here you have shortening of long bone, and then the epiphyseal dysgenesis. Okay, so you have that one. And then when you do your skull x-ray, there is a presence of your large fontanelle, and the sutures are wide here. So for the screening, you need, of course, to measure the T4 and TSH during the 48 hours of life. So, but sometimes there might be some false positive rates. Okay, so you need to have confirmatory tests. Okay, so if positive, no, you need to confirm. You have to look for the possible cause. So since the most common is thyroid dysgenesis or agenesis, so you need to do your thyroid ultrasound or thyroid uptake scan. And if you're entertaining maternal autoimmune thyroid disease, you need to measure the TSH binding inhibitor, IGs. No? And if you are entertaining possible iodine deficiency, so you need to measure urinary iodine. So ideally, okay, all newborns must be screened before they will be discharged from the hospital. Okay, so in the hospital, our practice is we do the newborn screening after 24 hours of life. Okay, it is a universal screening, and if in the absence of universal screening, newborns with following indications must be screened. Okay, so if you are in the area wherein this universal screening is not mandatory, no, so these are the indications that you need to screen your babies. So first, having clinical features of congenital hypothyroidism or even a family history of such, a history of thyroid disease or anti-thyroid medication intake in the mother, any presence of other conditions like Down syndrome, trisomy 18, neural tube defects, congenital heart disease, and so on. Okay, so if you have these indications, then there should be, ideally, these babies must be screened. So here is an algorithm, a diagram in the approach to a newborn with positive screening test for congenital hypothyroidism. Okay, so this is usually done, no, as part of the newborn screening. So screening on the filter paper sample. Okay, so you test there for your TSH and your T4. If it's normal, of course, there's nothing to do, no? But if it's abnormal, you need to do your thyroid scan. Look for the possible cause. Okay, look for an ectopic thyroid gland, no? So you have to consider that. And then you need to start treatment once, no? Once you have already this findings, okay? So here, if you're, when you do your thyroid scan, if there's no uptake, do the ultrasound, okay? If there's no thyroid gland, okay, you have to think of a possible thyroid. Of course, there's thyroid agenesis. If the thyroid gland is normal, still check for antibodies, because you might be dealing with presence of antibodies, no? If it's negative, you might be thinking about this, okay? If it's positive, so you will be dealing with this condition, having antibodies against the TSH receptor. So if there is ectopic uptake, so think about ectopic thyroid. If increased uptake, then you need to consider your iodine deficiency. So how do you treat congenital hypothyroidism? So infants with low T4 and elevated TSH should be started on your L-thyroxine as soon as possible, as soon as you made your diagnosis. So the initial dose of this is 10 to 15 micrograms per kilogram per day. And those patients with severe hypothyroidism, meaning they have very low T4, very high TSH, and absence of distal femoral and proximal tibial epiphysis, when you do your radiography, you need to start at a higher dose at 15 micrograms per kilogram per day. So how do you monitor these patients? No? So you need to follow this schedule, meaning to say you need to follow up the patient. You need to determine their T4 and TSH. So if the child or if the infant is 0 to 6 months, you need to do it every month. Between 6 months to 2 years, you do it every 2 to 3 months. If the patient is beyond 2 years, every 6 months. Of course, not only T4 and TSH, you have to monitor also the growth and development of the child. Okay, so 6 to 8 weeks after any dose change. So if in case that at this time you change the dose, you either increase or decrease the dose based on the result of your T4 and TSH. So you can do a repeat test 6 to 8 weeks after you modify the dose. And it takes less than a week for T4. So you have to remember this, that it takes less than a week for T4 to raise and 4 to 5 weeks for the TSH to normalize. So that's why you need to wait for 6 to 8 weeks after you modified your treatment. Because sometimes if you overtreat, patients may manifest craniosynostosis. Okay, or what is craniosynostosis? Early closure of the sutures, no? And patients may have temperament problems. Prognosis, okay, the final outcome is related to the nature and severity of the underlying thyroid abnormality, the age and diagnosis and when you started your treatment, and the adequacy and regularity of treatment. So compliance with regards to follow-up is very important in those patients. Okay, so that's why you really have to advise, you really have to educate the parents or the caretakers of patients having congenital hypothyroidism. So worldwide neonatal screening programs have a significant impact on reducing the intellectual deficits in hypothyroid infants, diagnosed and treated early. Okay, so that's very useful, no, in decreasing the incidence of patients with intellectual defects now due to congenital hypothyroidism. So early diagnosis and adequate treatment from first week of life would lead to normal linear growth and intelligence. Okay. So in severely affected infant with very low T4, with very high TSH, they may have reduced IQ level. Okay? And without treatment, for those infants without treatment, they may be have growth retardation and even mental retardation. And any delay in the diagnosis and even failure to correct the hypothyroxemia or even inadequate treatment and we have poor compliance in the first 2 years of life may result in certain degree of brain damage. And when onset of hypothyroidism occur after 2 years of age, outlook for normal development is much better, even if diagnosis and treatment have been delayed. Okay, so that's why it's very important being part of the newborn screening program. Okay, so let's go now to the this endemic goiter. Okay, so when you say endemic goiter, is a type of goiter that is associated. No, we're talking here about iodine deficiency. So it's very important in the iodination, no, of your T4 to T3, no, when after the formation of your T4 in the thyroid gland and it goes to the peripheral tissues. So you need that iodine. Okay, so in the WHO would require us to have this iodine supplementation. So for children 0 to 12 months, so I've shown this already to you, no? How much do we need, no? For 0 to 12 months, it's 50 per day, micrograms per day. 2 to 6, 90, 7 to 12, it's 120. For adults, it's 150. And for those women who are breastfeeding and pregnant, should be given 200 micrograms per day. So when do you say it's already endemic? No? If the prevalence of goiter is already more than 5%. It's just 5% of the population. Okay, so now we have the pandemic, no? It's more than 50% of the world, no? The population. So if it's considered, no, it is already considered endemic if it's more than 5% of the population. So if it's less than 5, it's no endemic. 5 to 19.9 is mild endemic. 20 to 29.9 is moderate, and more than 30% is already severe. Okay, so what could be the pathophysiology of this endemic goiter? Okay, so the goiter, so we have this swelling, no, swelling of the neck resulting from the enlargement of your thyroid gland. So iodine is, of course, it's very necessary for the secretion of your thyroid. Okay, or your thyroid hormones T4 and T3, and then the amount of TSH secreted by the anterior pituitary is regulated by negative feedback loop. So if the amount of the T3 and T4 gets high, then the TSH secretion will be decreased. But in iodine deficiency here, there is very little amount of your thyroid hormones T4 and T3. So thereby, there would be no inhibition of your TSH production, okay? Leaving the anterior pituitary to produce TSH freely, no? So it is not being inhibited. So excess amount of your TSH will cause the thyroid gland cells to multiply and divide excessively, resulting in goiter. So that's how your endemic goiter, no, your iodine deficiency can lead to the formation of your goiter. So what could be the risk factors or even the causes for this endemic goiter? Definitely low dietary iodine, even the deficiency of both iron and selenium. Okay, because these two are very important also for thyroid hormone synthesis. Pregnancy, no, there's increase in the requirement during pregnancy, so you need to give 200. Okay, and then radiation can cause that. Increased level of goitrogen, so there are some foods that can interfere with the iodine uptake in the thyroid gland. Some antibiotics, some foods. Cassava could be a goitrogen. It has higher occurrence in women. Okay, intake of oral contraceptives or even consumption of preserved foods, the pickled foods that contains thyrostatics. So the signs and symptoms of patients, no, with endemic goiter for fetus and neonates, they may manifest or they may lead, it may lead to cretinism. Okay, so they might have problems with stunted growth. It can also cause increased infantile or prenatal mortality. Okay, so this is fetal life, nor even neonatal period, or even they have this retarded bone growth. So how about in children? So children may have this goiter. I showed you already the pathophysiology in its development, physical and mental development delays, impaired sense of hearing and problems with speech, and even limb paralysis. And how about in older individuals, particularly the pregnant women and women of childbearing age? So there is a possibility of high incidence of congenital anomalies, reduced fertility, irregular menstrual cycle, increased incidence of spontaneous abortions and stillbirth. And for adults, okay, aside from goiter, they might be have this reduced IQ, risk of compression of the upper airways, increased risk of thyroid cancer, hypothyroidism, and even constipation and dry, flaky skin. And they might be usually they are what you call this, inactive, most of the time sleepy, no? And then they have this cold intolerance. So diagnosis, aim, of course, if you are dealing with patients who lives in country with high iodine deficiency. So I mentioned already about the Mongolia, no? So there is decreased iodine levels there, no? Because they are located in the mountainous region. Low levels of median urine iodine, high absorption of radioactive iodine, presence of goiter. Okay, so if there's euthyroid or hypothyroid state, and if you look at this thyroid hormones, T4 is decreased, but T3 is the synthesis of T3 is increased. Okay, and then there is increase in your TSH. Okay, so let's now go to hyperthyroidism. So with regards to Graves' disease, in pediatrics, it's less common compared to older in adult population. So it accounts only for 10 to 15% of thyroid disorders in patients less than 18 years of age. But with regards hyperthyroidism in general for pediatric patients, still Graves' disease is the most common cause of hyperthyroidism in pediatrics. Okay, and 38% of cases are or may occur before puberty. No, the diagnosis of which can be done as early as pubertal area or even period, no, and then it's more common in girls than in males. So we have this triad, no? We have the ophthalmopathy, so there should always be the presence of these three manifestations: presence of eye symptoms, skin symptoms, and of course, increase in your thyroid hormones, no? Presence of your hyperthyroidism. So Graves' disease, as you can see here, results from the production of your thyroid stimulating immunoglobulins, or your TSI. Okay, these are being stimulated. This results by stimulated beta lymphocytes. So these immunoglobulins will bind to the thyroid stimulating hormones. Okay, so we have this thyroid stimulating hormone receptors here to mimic the action of your TSH. So resulting in follicular cell growth, an increase in vascularity, and excessive synthesis and secretion of your thyroid hormone. So an imbalance between the pathogenic and the regulatory T cells is thought to be involved in both the development of the Graves' disease and its severity, leading to the production of your autoantibodies. Okay, so that is the pathophysiology of your Graves' disease. So how about this Graves' ophthalmopathy? So Graves' ophthalmopathy may result from the antibodies, okay, against the TSH receptor-like protein in the retroorbital connective tissue. So in children with Graves' disease, there's a positive association between elevated levels of your TSI, or your thyroid stimulating immunoglobulins, and also the development of ophthalmopathy. No? So it has been reported, the association of that. So these are the presentations, okay, of patients with hyperthyroidism. So symptoms could be hyperactive. So sometimes it could be a reason for the teacher, to tell the parents. It's not thinking about attention deficit. Okay, patients may just be super active in school, and then palpitations, sleep disturbance, fatigue, poor school performance, and so on. Okay, and of course with the signs, so you have goiter, presence of that mass there, tachycardia, okay, because of the increased thyroid hormones. There's weight loss, okay, you have heat intolerance, and so on. Okay, so these are the symptoms and these are the signs of your hyperthyroidism. Okay, so again, showing to you the percentages of the clinical features. Still, your goiter has the highest percentage, followed by tachycardia, nervousness, increased blood pressure, hypertension, and so on. Okay, so this is a person having the mass there, the goiter, and then these are the ophthalmic abnormalities, although as you can see here, they are less severe in children compared to adults. Okay, so diagnosis, of course, there are 3 ways to diagnose: clinically, by doing your history and physical examination, doing your thyroid function test, very high thyroid hormones and decreased or even absent TSH, and also presence of antibodies. Okay, you can do also your iodine uptake and ultrasound of your thyroid. So when you do your TFT, okay, thyroid function test, the serum TSH is suppressed, and most children have very high FT4 and FT3. And rarely some children will have typical features of the Graves' disease, but thyroid function tests will be normal. So they are being referred to as euthyroid Graves' disease. Okay, so to confirm this presence of your antibodies, I'm sorry for that. Okay, sorry for that. So to confirm Graves' disease as the etiology, you need to determine the levels of your antibodies. Okay, and these are detected in most of the patients, in 60 to 94% of patients. So the most accurate test for these antibodies is the measurement of your TSI, your thyroid stimulating immunoglobulin. So treatment, the optimal treatment of your Graves' disease in childhood, actually it remains a matter of debate. Okay, because the treatment is directed at alleviating the symptoms and reducing the thyroid hormone production. So the choice of therapy is determined by individual consideration of the risks and benefits of the three treatment modalities. What are those three treatment modalities? No? So we have the anti-thyroid drug, radiotherapy, okay, and your surgery. Okay, so actually most pediatric endocrinologists would recommend the anti-thyroid drug therapy as the initial treatment. There is, however, a growing acceptance of your radioactive iodine therapy for children older than 10 years and adolescents as a second option. And in some cases, they may use it as an initial treatment. And with regards surgery, near total thyroidectomy is an equally effective and safe treatment in patients with Graves' disease. So with anti-thyroid drugs, most children and adolescents would respond well to this anti-thyroid drug, okay, with 87 to 100% becoming euthyroid within a few weeks to a few months. And the problem with more prolonged use of your anti-thyroid drugs, to achieve remission, so you have to give a prolonged prolonged period in the giving of your anti-thyroid drugs, at least 2 to 4 years. And carbimazole and its methimazole are the drug of choice in treating these patients. So what could be the mechanism of action? They inhibit the thyroid hormone synthesis, of course, by inhibiting the oxidation of iodide and block the coupling of iodotyrosyl residues in your thyroglobulin. Whereas the propylthiouracil can also block the peripheral conversion of your T4 to T3. And how about remission? The rate of remission of Graves' hyperthyroidism in children and adolescents may vary from 25 to 65%. And 25% of children may go into remission every 2 years. And what about talking about relapse? What is its definition? It's the presence of suppressed levels of your TSH combined with high FT4 of 21 or FT3 of more than 11. So the relapse rate in children may be varied from 3 to 47%. Okay, so I think that's the end of my lecture. That's the first part of my lecture. So thank you so much for your attention.